About 35 years ago, there was a well-meaning surgeon who wrote an article for the New England Journal of Medicine. It was 2 paragraphs long. It was really just a letter to the editor. And it stated that in his time in seeing a few hundred patients who he'd given opioids to, he noticed less than 1% of those coming back to the hospital for treatment for addiction. When that got published, it was a blip, not even really noticed. Until about 1995, when Big Pharma determined that it now needed a new market for opioids. When that happened, one of their account executives found this article and decided to start using it as a basis for extending the use of opioid pain medications outside of the realm of cancer and into patients with non-malignant chronic pain. When they did this, they went into a lot of the primary care settings and into pain clinics and surgery clinics and talked to them about, look, there's no risk of addiction with these. We have this article that talks about less than 1% risk. And when they did that, we bought it. We bought it. This is actually, I think, probably the most difficult aspect for me to swallow about opioids for non-cancer chronic pain, is that there was a 2-paragraph letter to the editor, and we refused to go back and review the literature as scientists and practitioners. We try to blame it on the vital sign that they added, the 5th one, right? Can you remember what it was competing with? So pain as the 5th vital sign actually had a competitor at the time, and that competitor was very specifically oxygen saturation. So when that happened, we had to choose between the amount of oxygen in the blood, which we can measure, and has a little bit of something to do with whether you're dead or alive, or pain as a vital sign, which we can't measure. And last I checked, there's no mortality rate associated with pain, however frustrating. The bottom line of the CDC's reaction and the VA/DOD's reaction to this is to write guidelines. These guidelines were really there to direct how we should be using opioids, since we had 60,000 people in 2016 die of overdose. It really comes down to 3 things that we have to focus on. And one of those is patients should try all non-opioid pain medications first. Second, you should decrease or stop opioids for chronic pain. So if somebody has chronic pain, they shouldn't be on opioids long term because the data is very clear that it just doesn't work. And the real common theme is that opioids are bad. Before we dig into the guidelines for the CDC and the VA/DOD, I think it's important for us to look at what we could have learned if we had taken a very scientific approach to opioids in the beginning. And that means, what does the neuroscience show us that if we add opioids to the human system of pain relief, what happens? If we add opioids to the system, we have many pathways in our brain and spinal cord that recalibrate, and not in good ways. So let's talk about that a little bit. To evaluate the neuroscience, we have to understand the basics of the 4 main neuroscientific tracks that go up the spinal cord to the brain to tell us how to interpret a pain signal. If I twist my back and that signal comes in and it goes straight up the spinal cord, there are 4 different ways that it gets to the brain, and quite honestly, 4 different things that it does when it gets there. The first is the spinothalamic tract, or the cervicothalamic tract. Both of these are just the signal that if I twist my back, the signal comes in, it goes straight up, goes to the thalamus, and then tells me where that pain is coming from. So it's really built for location. The next one is the spinal-reticular tract. So if I'm sleeping at night and I roll over and twist my back, that's the tract that sends a signal to the reticular activating system. It wakes me up, and that gets stimulated with pain as well. The spinomesencephalic tract is another tract that's responsible for our emotional context of pain. So if I twist my back, the signal comes up to the brain, goes to the areas of the brain responsible for emotions, and I create an emotional reaction because of that. And then finally, we have the spinohypothalamic tract. This is responsible for chronic pain, changing a lot of the endocrine realities of our brain and how it affects our body from the endocrinological pathway. We also have descending tracts. These are the things that help to push back on the pain from those 4 tracts coming up. These help to regulate and monitor how our body perceives pain, and can we move through the pain, or is it going to basically stop us in our tracks? If we were to look at these, we have one that goes through the periaqueductal gray, which is an opioid-producing part of the brain, to the locus ceruleus, and then that goes down to the dorsal horn. This is important because the fight or flight mechanism relies on this basically blocking pain signals so that we can get away. The other one is the periaqueductal gray to the raphe magnus to the dorsal horn. This one is interesting because it's the one that really starts to work through mindfulness or relaxation pathways. And if we do those correctly, that acts as a brake in that dorsal horn and blocks the pain signal from coming up. However, if we're not mindful and we're not relaxed, what happens is that can then allow for more pain signal to come up. So if we panic, what happens is a chemical called enkephalin is released, and instead of blocking that signal, it actually allows more signal to come up. A question I get all the time is, well, who cares and why does the neuroscience even matter? Because we can learn about it and we can find the little places in the brain and the spinal cord where signals go, but how does that change what I do for a patient? Well, actually, it manipulates a lot, especially if we look at what the chemicals that we give the body do to the neuroscience. If I give you an opioid, that can manipulate the periaqueductal gray, it can manipulate the ventral medulla or the brainstem, and it can manipulate the dorsal horn. If I give you a medication that raises serotonin, that actually can change the way that the amygdala creates an emotional response and can change the way that the raphe magnus allows for that descending pathway to go down to the dorsal horn. If I add norepinephrine to the system or adrenaline to that system, that can change the way the locus ceruleus sends a lot of these signals both up and down. And then we have GABA, the unsung kind of hero of pain control. Because gamma aminobutyric acid works not only in the brain, but also in the dorsal horn. And in fact, all the manipulations that help to block pain ultimately do it by raising gamma aminobutyric acid concentrations. If we get in the way of it working, it can change the way that the body manipulates pain. So if I take a benzodiazepine, which mimics gamma aminobutyric acid, if I drink alcohol, which works on this gamma aminobutyric acid receptor, over time the body will be less sensitive to GABA or gamma aminobutyric acid, and therefore perceptions of pain will be significantly increased. And with this, our body will naturally have less of an ability to block that pain signal coming up to the brain. So let's walk through kind of what this looks like in the real world. In the real world, if you have a patient with a pretty, quote, normal pathway and a normal to high pain tolerance, although I have to say, a lot of my patients will say they have a very high pain tolerance, but when I come at them with a flu shot, you would think I was about to set them on fire. So you have to take people's description of their own, pain tolerance with a grain of salt. But if we take a patient and we have this kind of acute twisting of the back where they twist it and they get the twinge, the first thing that happens is they're gonna look around and be like, all right, am I okay? Did I get hurt? Did I step on something? Did I get poked with a stick in the back? But if everything's all right, then emotionally, they're okay. So this increases the descending inhibition. Remember those descending tracts that come down? It increases that signal, which helps to block the pain in the dorsal horn. When that happens, the pain signal not getting up to the part of the brain to make emotions worse, to make the parts of the brain responsible for location ping off with a bright light. They're not doing that as much because our brain has already assessed things are okay. So let's suppress the pain so that we can continue to move through what we need to. This happens through our own natural production of endorphins, which happens in the periaqueductal gray as well as in the dorsal horn. These endorphins are much stronger than any opioid that we take, and so it doesn't take much to help to tamp down the pain. So in the situation where I twist my back, I feel pain, I assess that everything is okay, my body does what it's supposed to do. It allows me to continue to move throughout the rest of my day. It keeps me from having a significant emotional response, and the pain gets tamped down naturally over time. So therefore, this equals less pain and greater function. Now let's look at a patient who has maybe less pain tolerance. Somebody who'll tell you straight up, I don't like pain, it freaks me out. What happens to them? How do they get through the day? Because they're gonna have a painful stimulus at some point. Well, the body has a backup for this, and this is really interesting. So let's say the same thing happens. You have a person with a low pain tolerance and they twist their back and it's chronically painful, but now it hurts a lot worse. Now they assess what's going on around them and they assess it's not all good. Not because they got poked with a stick in the back or hit by a truck, but just because in general, that's how they respond to pain. That means that spinomesencephalic tract is going off like crazy and sending signals to the amygdala to be panicky and fearful. When that happens, you get an increase in the descending enkephalon response. Remember, we said if you put enkephalon in there, it allows the signal to get stronger. So when that happens, you now have a patient who's getting worsening pain and they start to panic. That panic causes tachypnea, or an increase in the rate of breathing. When that happens, they get rid of carbon dioxide, and that hyperventilation that happens actually changes the pH and raises it. So when that happens, that blocks the pain signal from going up to the brain. This is interesting because we have a patient who has a low pain tolerance, but the body's aware of this, so it has a backup to the normal mechanisms. Because when it hyperventilates and it changes the pH, it does the same thing as if the periaqueductal gray made a whole bunch of endorphins. So we have one and even a backup system to handle pain in a natural state. So let's talk a little bit about what happens in an unnatural state when we add an opioid to the system. When we add an opioid in an unnatural way, meaning I write a prescription and that person takes pills for that, or back in the late 1800s and early 1900s, or 500 years ago when we would use opium laudanum. I mean, this has been around for a while. And even back then we realized that this wasn't a good, treatment for long-term pain. Although long-term pain back in the 1800s meant that you had pain until you were 34, since that was the average, lifespan. So we didn't have to deal with the 30 years of opioids. Only recently have we had to look at what that feels like for patients. And now that we look at it from the neuroscience perspective, we find out why this is bad. So when you give an opioid, the body says, I don't need to make as much of my own endogenous opioids, meaning I don't have to make my own endorphins nearly as much, because it's getting it from the outside. So the periaqueductal gray, the ventral medulla, and the dorsal horn just don't make any more opioids. They phone it in. They're like, somebody else is taking care of this. So the body also ramps up the pain signal to overcome those outside opioids. So that means if I'm taking an opioid and the pain signal's not getting through, because pain is protective in a natural state, then it's going to ramp up the pain signal to where finally it breaks through and gets to the brain. So not only have I decreased my own opioids, but I have increased the signal that's coming up to the brain to tell me that I have pain. That doesn't sound very good for many reasons. As we look at the pain in a patient in this setting, they start to get what we call hyperalgesia, which is where they have pain for a non-painful stimuli. So it's like the patient where you go in and you're going to examine them in the examining room and they have back pain, and before you can even really touch their skin, you just brush against the shirt and they jump off the bed and they're like, oh, it hurts, it hurts. And that's pain to an unpainful stimuli. And this happens because you have this intensity of pain signal and the body's not doing its job of dampening that because of these outside opioids. So you get more pain in a widened area. At this point, because we've decreased the endorphin production from the periaqueductal gray and the dorsal horn, we also have this other phenomenon from, remember that reticular activating system? When that happens, that signal that came up and makes us wake up if we rolled over on attack, now is active all the time. When that is active all the time, patients with chronic pain, especially those on an opioid, are not getting good sleep. And that sleep cycle over time gets really wrecked. And when you don't have appropriate deep sleep, then you start to have emotional lability issues where you can't really maintain your capability to be calm. And if you can't be calm, it's hard to think and focus. And so we find difficulty in cognitive skills. We find difficulty in task orientation. These are really common in chronic pain patients on opioids because we are not allowing the body's natural systems to work. So now let's think about this patient from a sense of what if they twisted their back? So they assess the situation, and whether or not they feel like everything is okay or not, it's kind of out of their natural control because we've given them a chemical that's changed all of these mechanisms. So we get an increase in the descending excitatory pathway, which means that enkephalin turns on and allows more pain signal to get through. All four of those ascending pathways are cranking out as much signal as they can. And then we also don't have this inhibitory pathway that we would normally have from the locus ceruleus. Remember we talked about periaqueductal gray to locus ceruleus with norepinephrine and going down? It's not able to fire off because the periaqueductal gray is clouded with the outside opioid and it's not able to turn on that signal. So we have an increase in pain. We have a little bit of hysteria. But the problem with this version of hysteria is that the opioid is blocking the tachypnea because opioids cause respiratory suppression. So not only have we wrecked the primary form of pain control, but we have dampened the backup control. So now what we have is somebody who has horrible pain, definitely out of proportion to what the injury was, and whether or not they assess things were good or bad, they start to have some panic and a little bit of hysteria. But because we're blocking the rate of breath, they don't get the pH change. And so no matter what they do, the pain stays the same and in many cases gets worse because we're not able to even produce the opioids that we need in our periaqueductal gray or our dorsal horn. For a lot of these patients, it feels like they're ultimately on fire because the C fibers, these little bitty pain fibers that sit in the skin, also start to ramp up their signal, thus causing widened, worsening, terrible pain. If we could have just listened to the neuroscience, if we could have read a little more than the 2-paragraph New England Journal editor's letter, we would have been in a much better place and we wouldn't really have required the federal government to develop guidelines to tell us how we should not be doing what we're doing. But that's where we are. So for the rest of this lecture, what I want to do is go over, in pretty short form, the CDC guidelines, the Centers for Disease Control guidelines, and the VA DoD guidelines, the Veterans Administration Department of Defense guidelines for the use of opioids in the treatment of chronic pain. They all have kind of the same general approach that we talked about at the beginning. Remember, opioids are bad. Use everything except opioids if you can. And if they're already on opioids, decrease it or stop it. But the CDC did get a little more specific, and so did the VA DoD. So what we're going to do is go through the overview. I'm not going to dig into each of these specifically because it's a little too much to have to figure out and to take. But as we go through these, what you're going to find are consistent themes. And these, again, match what we found with the neuroscience. And if we had listened to that, we would know that mindfulness would increase the descending pathway and inhibit pain. That, exercise would increase our own production of endorphins. All of these things would have been known to us, but now we're going to look at the what not to do pathways that the CDC and the VA DoD have developed. So the CDC has 12 basic recommendations. The first is start with non-pharmacologic therapies. That means mindfulness, yoga, exercise, all of those things that we have pretty large amounts of data for in randomized controlled fashion. So mindfulness and yoga are the two largest cohorts of data that we found to treat chronic lumbar spine pain. Yet rarely are those paid for appropriately and rarely are those available. But we need to start shifting toward that based on the first recommendation from the CDC guidelines. The second one, you have to set realistic treatment goals. Realistic treatment goals means, you might have some pain. So we're gonna have to figure out how to deal with that. And when we start physical therapy, your pain might go up before it goes down. Not, we're gonna give you some meds, it's all gonna be fine. I heard that in the hallways of the hospital many times, where somebody would walk in and say, I know we're gonna cut your belly open and we're gonna take out some of your organs and we're gonna sew it all up and put it back in. But you know what? you're going to have no pain. It's going to be good. We're going to be fine. You're going to wake up from the operating room and you're going to go home. That's unrealistic. So stop. Please don't do that anymore. Be realistic. Say, you know what? When we cut your skin open, the body has a reaction to that. When we do the surgery that we need to, the body may not like that at that point. So we're going to do our best to keep the pain tolerable and maintain your function. But we're going to have to work together to figure out what the best safety margin is with the pain treatment margin. The third is you have to do a thorough and consistent evaluation of the risks and benefits and alternatives. We don't do a good job of informed consent. An informed consent should say, oh, by the way, the medicine I'm going to give you, greater than 45,000 people died of last year. Any questions? I think if we had a heart medication that we gave people like that, most people wouldn't say yes to that. We took a non-steroidal completely off the market because a few people may have died from premature heart disease. Yet we keep opioids still front and center for the most part. And instead of starting with longer-acting opioids, what we want to do is move more toward short-acting opioids. So if you decide that you have to write it, if you're going to write it for these patients, start with short-acting opioids before you go to long-acting, and really only save long-acting opioids for patients that we've failed everything else and we ultimately have to go to long-term opioid therapy. Also prescribe the lowest effective dose. Don't start off with, I'm going to give you extra just in case you have some extra pain. Write the lowest dose that does the job. And the job is not pain-free. The job is this mixture of decreased risk with stabilized or increased function. You definitely have to decrease the length of prescription. And the length of prescription is not, well, here's 30 days, come back and we'll see how things are going. The data is very clear on this as well, where 3 to 7 days is really all you need. Even post-operatively, even after we cut open the skin and took out an organ or did a bone repair or whatever, 3 to 7 days, the data says, is what you need. Any more than that, and we start to run into trouble with respiratory problems, with pneumonia, with readmissions, with falls. So 3 to 7 days, and if they need to be reassessed, they should come in and have a reassessment. Recommendation number 7 from the CDC is pretty clear in that if you have a patient who is on long-term opioids, they need to be reevaluated not only within the first month, but every 3 months after that. Recommendation 8 is a little bit redundant, but I think can be separated out to say, do a risk assessment prior to initiation. This should be a part of the risk, benefit, and assessment of should we use these meds, but you have to do a specific and validated form of risk assessment. And we have a number of these on our screening section on the website, so feel free to go and look at those. And these are like the opioid risk tool, where you can decide whether or not their risk is too high to even start opioids. Or the COM, which is where if you have someone on opioids, it will allow you to know whether or not you should continue that or go down. And then things like the ASSIST or the DAST, which are ultimately addiction evaluation assessments. Again, all of those are in different places, but they need to be validated, not, so what do you think? Validated scientific format for assessing risk. Number 9 for the CDC is to check a prescription drug monitoring program. And as of this filming, every state except for Missouri has a PDMP. So check it, because it'll tell you if they filled prescriptions for other controlled substances, even if they paid cash, or if somebody got it off of their insurance. You need to do routine toxicological studies. Those toxicological studies and how to interpret those are listed in the American Society of Addiction Medicine guidelines. Those were just put out late in 2017 so that we can take a look at what it is we should be doing if we're checking a urine or an oral fluid. Definitely, number 11 is important. Do not co-prescribe benzodiazepines. Co-prescribing of benzodiazepines is directly related to a massive increase in the risk of accidental and purposeful overdose. So you want to stay away from co-prescribing benzodiazepines and opioids if at all possible. And I think, quite honestly, it's just possible. And number 12 for the CDC is you need to be able to assess and refer a patient for an opioid use disorder, which means you need to do a standardized screening tool, see if they meet the diagnosis for an opioid use disorder based on the Diagnostic and Statistic Manual 5 or the ASSIST or the DAST that I talked about. And then if you find it, either treat it in place and have that capability, or definitely be able to refer. And now let's take a look at the VA DoD guidelines. They came about a year later. It was a really inclusive process when they developed it internally, and they go a little farther, but it looks pretty much the same. So the CDC says opioids are bad, and here's a whole bunch of reasons they're bad. Well, the VA DoD says opioids are bad, and here's a whole bunch of other reasons that they're bad. But I think it's worth walking through each of these so that you can see the subtle differences between the two, both of which have a large amount of data behind it and would be considered level 1A or 2A. And with that allows us to feel very comfortable in having a conversation with the patient. Because in the past, it's been hard to say, I just know that they're not good for you. But now we have guidelines that we can point to, and that really does cement the conversation with the patient in a positive way. The first one with the VA DoD guidelines, and they had about 18 plus or minus. They had a few sub-points, and so we've spread it out a little bit. But the main one that they started with was, do not start long-term opioid therapy for chronic pain. This is because within the VA population, they have a large group of people who come back from in-country and in combat situations where they have not only chronic pain, but also depression, anxiety, some PTSD. And so the overlap of those two really creates new and bad problems when you start to overlap adding opioids onto someone who not only has chronic pain, but has depression or PTSD. We dig into that quite a bit with our archetype Raymond, and you can watch his lectures to see exactly what we would do for him. The second one for the VA DoD guidelines is use alternatives to opioid therapy. Now, what are alternatives to opioid therapy? Because that could be, well, you cut the head off a chicken and walk around the kitchen and hope that it works and you can put a chant. That's not an evidence-based alternative. So what we want to look at are self-management strategies like mindfulness, other non-pharmacological treatments like exercise and yoga, physical therapy, all of those that really start to develop core strength and increase the body's natural production of endorphins, and really maximizing all four of those ascending pathways and the two descending pathways. If we do that, we're more likely to get someone who, even if they have pain, still has function. Definitely, if you're gonna pick a pill, use non-opioid pharmacotherapy. And we'll talk a little bit about what that looks like in a number of other lectures, but the general concept is if a patient needs something to take to help them, start with basics like ibuprofen and Tylenol. And if those don't work, move to things like gabapentin or move to other medications like serotonin norepinephrine reuptake inhibitors. There are a lot of things to choose from, but don't just throw the bucket at them with these either. Make sure that we're focusing on what problem we're treating, but definitely don't start with an opioid. The next one is if you're gonna write for opioids / somebody had surgery or they had an injury, 3 to 5 days. We talked about for the CDC that they said 3 to 7 days. Well, they've tightened that up even more in the VA DoD to 3 to 5 days. The next one is gonna be for patients currently on long-term opioid therapy. They recommend ongoing risk mitigation strategies, and there are some specific ones that everyone should be doing if you're writing any controlled substance, not really just opioids, but opioids, benzos, stimulants. These risk mitigation strategies have been shown to decrease risk to the patient, to the household, and to society as a whole. And one of those is definitely assessing for opioid use disorder. The other one is consideration for tapering patients off of these medications. And there are a number of other ones that we'll get into later, but I'm going to hammer on these over and over again because these should just be standard of care. No long-term opioid therapy for pain in patients with an untreated substance use disorder. This seems like duh, right? However, when we look at the data, we find there are a large portion of patients who have either an alcohol use disorder, benzodiazepine use disorder, or opioid use disorder who still get a prescription for opioid pain medication. If you're going to assess it, make sure that you understand that writing an addictive substance for a patient with an addiction is not necessarily a good idea unless you are an addiction treatment professional. And even then, you have to really start looking at the risk and benefits through a completely different lens. The VA DoD also agrees with the CDC that you definitely should not write benzodiazepines concurrently with opioids. Again, risk of overdose death, both accidental and purposeful. And the next one is no long-term opioid therapy for patients less than 30 years of age. This one is unique to the VA-DoD guidelines because they have a much younger group of people that they work with, and they have found that if you write opioids for patients long-term and they're less than 30 years of age, that they have an increased risk of suicidality, an increased risk of depression, an increased risk of premature death, and an increased risk of overdose. So not a great idea. And I think this is not just for military professionals. I think this really does apply to the population as a whole, because if you're less than 30 and you're having to put somebody on chronic opioids, especially for non-malignant pain, you're asking for trouble. The next one is a little bit more extensive, and this is where we start to dig into some of these risk mitigation strategies a little more deeply. And this talks about not only doing them, but implementing a whole strategy around this. So a package of risk mitigation strategies should be a part of your everyday life inside of medicine if you write for a controlled substance, and specifically for opioids. So one, just like the CDC says, start with informed consent. Make sure that informed consent is evidence-based, that they know the risks and the benefits and the alternatives, and they can walk through each of those. You want to do ongoing random urine drug screening. This is important because if a patient knows that they're going to be tested on a Tuesday, and every Tuesday that they come in, then they can start to plan how that is. And the thing that we have found in addiction treatment and even stable monitoring of patients is the random piece of that changes the way that the brain perceives risk. And if it's random, that perception of risk does change behavior in that patient, meaning they're less likely to stray from what you have prescribed for them to do. You definitely want to check the PDMP. Again, that's just like what we talked about on the CDC guidelines. Monitor for overdose potential and suicidality. There are specific monitors that you can use for overdose potential and suicidality, and we'll talk about those in a different lecture, but at the same time, in this population, definitely doing consistent risks of suicide, and we have a number of indicators now that we can look at. Providing overdose education, and not only just providing overdose education to family and friends and the patient, but also prescribing naloxone. Naloxone is the medication that we give. It reverses an overdose. Really important. In fact, should just be mandated for anybody on long-term opioid therapy, and in many places it's being written concurrently most of the time. The reason this is important is it is an antidote for death. If somebody is dying from an opioid overdose and you give them naloxone, they don't die. That is important. And nobody's selling naloxone on the street. This is something that should just be in big buckets on every corner and in everybody's bathroom and in every parent's back pocket who has a loved one or a child on a controlled substance, specifically opioids. Every 3 months, just like the CDC, you have to continue to evaluate for risk versus benefit. So just put that into the normal pathway. People will say, well, how do we do all of this stuff? You know, we check blood pressure and blood sugar and weight and all of these things every time somebody walks into a primary care clinic. You just have to make it a part of the normal daily pathway. If you don't do that, then what you're going to have are patients that die. You'll be unaware of why that happened, and you're going to continue to cause harm. So build these into the structure. And just again, like the CDC, the lowest dose of opioids that does the job. Don't write them for a big dose because they say it's not working. The lowest dose. And the job, again, is defined not as pain-free, but functional and pain tolerant. Those are really important. One of the additions that the VA-DoD guidelines brings is an importance of understanding that as you increase the dose of opioid medication, you need to correspondingly increase the dose of evaluation and monitoring. So that means if you go above 90 morphine milligram equivalents, or MMEs, then instead of every 3 months, maybe you should be assessing every 2 months or every 30 days. So as the dose goes up, so does the dose of monitoring. And that means more frequent urine toxicological studies, that means more frequent visits, that means more frequent screenings. All of those things should accompany any increase in dose, because as that goes up, the risk goes up. And the risk is not that the patient is dissatisfied, it is that the patient dies. The other one is don't prescribe long-acting opioids for acute pain. This seems like a no-brainer because if it's acute pain and you break your ankle or you hurt your shoulder or you hurt your back, we don't necessarily want to give you a medicine that lasts for a long time. We learned this lesson again, the hard way with methadone, when we were prescribing methadone for pain, and it can work a little bit when you first take it, but it doesn't peak for about 4 to 5 days of taking it. And so people would take methadone just like it was a Tic Tac because it wasn't helping their pain. And then those doses would stack and stack and stack and stack to the point where they went to sleep one night and they didn't wake up the next day. So using long-acting opioids on a patient with a short-acting pain makes no sense. So acute pain, short-acting opioids only. The VA/DoD also recommends tapering to a reduced dose or discontinuing long-acting opioid therapy when the risks of long-term opioid therapy outweigh the benefits. This can be interpreted a bunch of different ways, and the best advice I can give for this one is have a good conversation with your patient. Like, talk to them. How are you doing at home? How are your relationships with your family? Do you still have your job? Are you able to concentrate? Are you sleeping well? Do you have constipation from the opioids? Do you have all these other cognitive side effects? Walk through each of these, and you're going to start to say, if the patient is depressed, their pain is still not controlled, they have a lot of side effects, those are all risks, definitely not benefits. If the patient's function is improved and their cognitive capability is fine and their function is better, great. Then it's doing what we had hoped it would do. But I'll tell you, after treating thousands of patients, I've had like one that I can say that as we increase the dose of opioids, I found an increase in function rather than an increase in risk. But if you're going to taper somebody, and this is really important, if you're going to taper somebody or you think that they don't need to be on opioids, do not just turn that light switch off. Don't just stop it. That will put them into profound withdrawal, cause a significant amount of distress, and absolutely be the worst thing you can do for building trust in your patient. Identify that we want to get it off, explain it to them, and we have a number of different videos talking about withdrawal management of opioids and how to best get someone off. But the rule of thumb is if you want to taper them and they need to get off, just decrease by 10% per month until they're done. Take your time. If it's dangerous, you can go as fast as 25% every 2 days with other medications. And again, we have videos talking about that, but don't just turn it off. Don't fire a patient and give them no way to treat their withdrawal. Don't just turn your back on them. That is unethical and, quite honestly, immoral, especially in a field where we stated that first do no harm is our mantra. If possible, and this is a tough one, so the VA/DoD is unique in that they have a lot of people in the same hospital. They can put together different teams. Their payment model is different. It's basically one large accountable care organization where they get a bucket of money to take care of patients, and so they can manipulate teams a little more easily than most of us. But they do state that interdisciplinary care for pain, if at all possible, is the best way. As someone who built and ran an interdisciplinary clinic, I would agree with this because there are many things as a prescribing provider, as a doctor, that I couldn't do that my behavioral therapist could do. There are things that my behavioral therapist and I couldn't do that our case manager could handle, that our community health worker could go out and help this patient, that our sobriety coach could help stabilize them with. So an interdisciplinary team is superior, and there's plenty of research to show that that's the case. It may just not be what you can do in your own office. And if that's the case, we do have some treatment system development information that'll show you how to best connect with those around you to create, kind of an amalgam of an interdisciplinary team, even if they're not all in your same office. A big one, and one that I didn't think would be as hard as it is, since we have almost every doctor who felt comfortable writing oxycodone, I felt like it wouldn't be that hard to get physicians and PAs and nurse practitioners comfortable with writing things like buprenorphine for opioid use disorder. However, less than 3% of primary care doctors are waivered to be able to write for buprenorphine. And the VA/DoD recognized this, and they state that you have to be able to offer medication-assisted treatment for opioid use disorder. This is something that's a big push within the VA/DoD, as well as out in the mainstream medical treatment world. And I know it's tough and I know it's difficult, but at the same time, if you can write the medicine that caused the problem, you should be able to write the medicine that stabilizes the problem within your clinic. This also means being able to write for naltrexone, whether it's oral or injectable, and referring for a methadone clinic or an opioid treatment program if that's the right pathway for your patient. Using alternatives for opioids is something else that they talk about in the VA/DoD, especially in mild to moderate acute pain. In fact, don't even bring up opioids to begin with if it's only mild to moderate pain. If that's what it is, using multimodal pain care, and that's just a different description for interdisciplinary team, but multimodal also is, I'm going to do physical therapy and mindfulness and take a non-steroidal. That's a multimodal approach. We're working all of those ascending pathways, descending pathways, and the cognitive capability of this patient all at the same time. So doing a therapy, both physical and mental, as well as adding a medication, can be really helpful to getting a patient's function improved and decreasing their overall pain. If take-home opioids are prescribed, this is another big one in that you have to recommend immediate release opioids and not the long-acting. We're going to harp on this over and over, and the lowest effective dose and only for 3 to 5 days. The guidelines make sense if we applied them to neuroscience, right? I mean, these are kind of the CDC and the VA/DoD, the vast majority of these things overlapped. There were very few things between them that were a little different, and most of the things that were different was because the VA sees a little bit of a different population. So with this, we need to realize there are many opioids to choose from, whether they're short-acting or long-acting, how you ride them for 3 days or 7 days. But the most important question is to really sit down, have a conversation with the patient, and determine whether or not you should ever write for the first one.